Last week, I have created one video related to inpatient coding Q&A where I have provided latest Q&A from all MNC companies in India, USA and UAE where I have provided latest like those are in 2025 Q&A related to inpatient coding. So today we will learn part 2 of the inpatient coding Q&A. Here we will learn approximately 25 plus questions and answers. So this is the video I am discussing. So latest 100 plus inpatient coding Q&A. So few coders requested me to provide lesser length videos so that I have reduced the Q&As. So this video consists of total 100 Q&A already published. You can check in our playlist. And today we'll see only 25 Q&A as most of the coder requested me to provide very less duration videos. So today's first question is types of documents which we have to handle in IPDRG accounts. So basically in interviews they may ask you like what are the documents you need if you want to code IPDRG chart or inpatient coding chart. So whenever you want to code IPDRG charts, you need to have discharge summary where complete patient's encounter will be included, progress notes where you will get patient's status day by day and consultation reports, pathology reports, operative notes or procedure notes if the patient undergone any type of procedures, history and physical, emergency department documents, case management notes, radiology reports, physician orders. Sometimes we may use nurses notes for BMI, NIHSS, GCS, pressure ulcer stage and site. Okay. So basically if you want to code any inpatient chart, these are the mandatory documents you need to check before coding any inpatient chart. Okay. So what is the next question here? Elements in the IPDRG. So what are the elements in the IPDRG you need to follow? So in the IPDRG charts we have multiple elements. These are the most important elements we need to follow while coding the inpatient chart. First one is admitting diagnosis. Okay, so basically admitting diagnosis means what is the reason for patient's visit. Okay, most of the time we need to use ED and HMP documents for admitting diagnosis. Okay, so what is the admitting diagnosis? So admitting diagnosis is the symptom or the condition which is mentioned by the patient on the day of admission. Okay, so as soon as the patient came into the hospital, most of the time based on the complication he may go into ED, and after admitting into inpatient he will have the HMP document. So you need to check ED and HMP documents for admitting diagnosis. Okay, so this is the first or initial symptoms which is described by the patient on the day of admission. Next one is principal diagnosis. So in the documentation you will see admitting diagnosis as ADX. Okay. Next one is the principal diagnosis. So basically as all of us know, principal diagnosis is the heart of the inpatient account. Why means as if you are new to inpatient coding, so in inpatient coding reimbursement will depends on PDX. This PDX is as in having the DRG values. So based on this DRG only, patient will get the amount or facility or hospital will get the amount. So here PDX is the heart of the inpatient account. Okay, what is PDX? So after the study, the condition which is chiefly responsible for patient's admission or the condition which leads to patient hospitalization. So basically PDX is the condition which is chiefly responsible for the patient admission after the evaluation, not the before evaluation. So before evaluation is admitting diagnosis, after the evaluation is principal diagnosis. Next one is secondary or additional diagnosis. So along with PDX we need to use SDX also. Usually we'll call it as secondary diagnosis, which will depends on MCCs and CCs, which we will let soon in the few upcoming videos. So what is secondary diagnosis? So secondary diagnoses are coexisting with principal diagnosis. Okay. So these are the coexisting conditions where physician needs to provide evaluation to secondary diagnosis also. Okay. So these secondary diagnoses may be present on the day of admission or may not. But we need to code secondary or additional diagnosis also. So far we have admitting diagnosis, principal diagnosis, secondary or additional diagnoses as which are related to diagnosis like ICD-10-CM codes. Okay. Next we have principal procedures where we will use ICD-10 PCS. Okay. So what is principal procedure? So principal procedure is surgical treatment which is directed for the principal diagnosis. Okay. So basically you need to check the medical necessity here. Okay. So based on your principal diagnosis, you need to code your principal procedure or vice versa. Next one is secondary or additional procedures. Okay. So like secondary diagnosis using ICD-10-CM, we need to code secondary or additional procedures also. Okay. So these are also coexisting with principal diagnosis. Next question, what are the elements of or what are the criteria you will follow while assigning secondary codes? Okay. So whenever you want to code secondary diagnosis codes, you need to check for that condition whether if the patient has performed any diagnostic workup, whether patient has performed any therapeutic treatment, or whether this condition is increasing the patient's inpatient stay, or whether this condition is increasing the care, or whether this condition is having any clinical evaluation by the physician, or it may extends the length of stay of the patient in the inpatient setting. Okay, so then only you can code secondary code. Okay, so these are the criteria. In the interviews they may ask you, so what are the elements to consider secondary diagnosis? So that time you need to tell all these 5 steps. Okay, in order to code secondary diagnosis, physician must need to do all these steps. Any one step is enough. So all these 5 steps are not essential. Any one is enough in order to assign secondary diagnosis codes. Okay. Next one is what is DRG? So this is very important. As we have discussed previously, DRG is the heart of inpatient record. Okay. So DRG system is to classify hospital cases into or causes into 467 groups based on the severity of the diagnosis. Okay. So basically based on the severity of the patient's diagnosis, we have 467 groups. If you know or if you want to learn these 467 groups, please mention in the comment section of this video. Okay. And we have major diagnosis categories. MDCs in the DRGs are 25. Okay. DRG is manually established for uniform billing or uniform payment. Okay. So all inpatient charge based on DRG only, facility will get the amount. So we have 3 types of DRGs. MSDRG, usually we'll call it as Medicare Severity Diagnosis Related Group. Next we have APRDRG, All Patient Refined Diagnosis Related Group, and SDRG, Severity Diagnosis Related Group. Just and one DRG value classified into 3 types. Okay, so if you want to code DRG, you need to check for with MCC, major complications and comorbidities, with CC, complications and comorbidities, without CC and MCC. So basically your DRG value depends on these CC and MCC also. So if you want to learn about this MCC and CC, please mention the comment section of this video so that I can create separate videos related to MCC and CC. Okay. Next, what are the CC and MCC conditions? Okay. So CC and MCC conditions are complications which increase the severity of the illness and increase the complex treatment, which includes or extends the length of stay. Okay. So basically these CC MCC conditions are the secondary diagnosis. These will increase the patient's length of stay and patient's treatment also. Okay. So documenting the presence of one or more CC MCC condition will impact the DRG. Nothing but inpatient hospital reimbursement because these are increasing length of stay and other conditions which are mentioned above. Okay. So basically these conditions will impact the DRG assignment. So you need to apply or you need to choose the appropriate CC MCC based on the like diagnosis and patient's documentation. Okay. So what are the common MCC conditions? So acute respiratory failure, acute and chronic systolic congestive heart failure, COVID, severe protein calorie malnutrition, metabolic encephalopathy, ESRD, pneumonia, sepsis. So these are the common MCC conditions. Next, these are the common CC conditions. Okay, so MCC is more severe than CC. Okay, so chronic atrial fibrillation, chronic systolic congestive heart failure, coronary artery disease, chronic kidney disease state, 4 to 5, hyponatremia, UTI, acute renal failure, malnutrition, pleural effusion, atelectasis, and ascites. So these are the CC condition. So if you go to interview, they may ask you what are CC and MCC. Tell me few examples related to CC and MCC. That time you can tell this definition as well as these example conditions. Okay. Next question: what are the factors affects MSDRG? As we have discussed previously, MSDRG will affects by principal diagnosis 80%. So that is the reason in inpatient coding, principal diagnosis is the main condition which will affect the most of the reimbursement. Okay. Secondary diagnosis including MCC and CC, principal procedure, additional or secondary procedure, discharge disposition, age of the patient, sex of the patient, and birth weight. Okay, so these are the condition affects the MSDRG. Okay, so what are the factor affects the APRDRG? So if you don't know about APRDRG, please mention in the comment section. I will create one video related to APRDRG. So APRDRG depends on SOI, severity of illness, ROM, risk of mortality. These are the scenarios or conditions which will affect APRDRG. Okay. So next one, what is rule out and ruled out? So this is very confusing. Sometimes physician will mention rule out and sometimes he will mention ruled out. So here, so basically this is useful for both outpatient as well as inpatient coders. Okay. So what is rule out basically? So rule out means the patient suspecting the condition, it may present on the hospital admission. Okay. Rule out. Basically, patient is suspecting the condition. So that time he will mention rule out. For example, if the patient feels, for example, patient is having the nausea. Okay, in the documentation, physician may tell rule out appendicitis. Okay, here physician is not confirming patient is having the appendicitis because of patient symptoms. Physician is suspecting, so that time he will mention rule out. So rule out means basically suspecting. So next one is ruled out. So condition is not present. So basically after the evaluation, if the physician identifies that patient does not have any appendicitis, that time he will mention ruled out appendicitis. Means he is telling patient does not have any appendicitis. Okay. So here based on nausea, physician will treat the patient. He will not proceed with any procedure here. Why means here physician is directly telling ruled out appendicitis. Ruled out means patient is not having any appendicitis. Simple. Okay. Next, POA indicators. So these are very important for inpatient coders. So you need to understand what are POA indicators. So POA indicators give the information for a particular condition that is present on the day of admission or not. So basically POM is present on admission. So basically these indicators will represent if the condition is present on admission or not. Okay. So if you keep Y in front of POA, you are telling the insurance payer that so patient is having that condition. So no means, for example, if you append no or N, condition is not present on the day of admission, which is established in the middle of the hospital stay. So we are telling the payer that patient does not have any this condition. Next one is E, status post history conditions. Okay, if you append E to your diagnosis, so this is most of the time we will use E for status post history conditions. Next, under undetermined, the condition which is undetermined by the coder as well as the physician unable to find the condition is present on the day of admission or raised during the hospitalization. If you, as a coder, you and the physician also confused whether the patient is having this condition during the admission or not, you will keep U. Okay. So if you keep W means clinically undetermined. Clinically, physician is unable to identify whether this condition is acquired by the patient during the hospital or before the hospitalization. That time you will use W. Okay. So next, if you go to interview, they may ask you what are clinical indicators. Okay. So clinical indicators plays important role in the inpatient department or inpatient coding. Okay. So clinical indicators are nothing but symptoms which gives information about a particular disease to confirm or to query. Okay. So basically these clinical indicators are the symptoms. Based on these symptoms, patient will suspect, rule out few conditions. Okay. So for example, in the operative report, if we see SpO2 is less than 80%, blood pH is less than 7.3, PCO2 greater than 50 mg, PaO2 less than 60 mg, respiratory rate greater than 35 per minute, intubation is needed. If patient is admitted with respiratory insufficiency, check for respiratory failure. Okay. So these are the symptoms for acute respiratory failure. Simple. Okay. So these are the symptoms for acute respiratory failure. These symptoms technically you will call it as clinical indicators. So these are the indicators for acute respiratory failure. So next, when there is localized infection, we should check these below mentioned indicators. For example, if you suspect or patient suspect sepsis. Okay. So these are the clinical indicators for sepsis. Okay. For example, these if the patient is having all these symptoms. Okay. So basically symptoms are clinical indicators. So these are the clinical indicators for aspiration pneumonia. So these are the clinical indicators for anemia. Okay. And these are the clinical indicators for acute renal failure. Okay. So next, these are also clinical indicators for acute renal failure, and these are the clinical indicators for congestive heart failure. So if you see ankle edema, so patient needs to work towards congestive heart failure treatment. For example, if the patient is having elevated troponin, elevated BMP, so these are the clinical indicators for congestive heart failure. Okay. So these are the clinical indicators for malnutrition. Okay. So these are the clinical indicators for cerebral edema. Okay. Next question in the interviews, they may ask you what is the difference between so pressure and non-pressure chronic ulcer. Okay. So pressure ulcer basically because of continuous pressure on the same location. Okay. Pressure ulcers are injuries to the skin and underlying tissue primarily caused by prolonged pressure on the skin. They can happen to anyone, but usually affect people confined to bed or who sit on the chair or wheelchair for a longer period of time. Okay. These are the pressure ulcer. Non-pressure ulcers, if there is poor circulation, such as that caused by venous or arterial insufficiency or excessive moisture or trauma, may develop non-pressure ulcers. Okay. So these are the differences between pressure ulcer and non-pressure ulcer. Next, how many charts do you will do in daily basis? So most of the time in inpatient coding, we need to code 8 into 22 charts. Okay. So what are the charts we will code in the inpatient coding? So OB charts, newborn charts, surgery charts like orthopedic, cardiac, general surgery, and as well as neurology. Okay. So psychiatry, sometimes we will get psychiatry charts also, oncology, bariatrics, uh, and pediatric charts as well as internal medicine. So here basically you don't need to type or you don't need to mention all these types. Basically you need to mention whatever the charts you have coded in during the live coding. Just you can tell. For example, if you have coded OB and newborn, most of the your inpatient coding experience. Just you can tell OB and newborn. So what is quality? So how much quality you have provided during or in your previous company? Okay, just you can tell them. So I have provided plus 95% including all element SDX, PDX, CC, MCC, PCS, POA, discharge disposition as well as DRGs. Okay. So please tell me the recent errors came from the smart auditors. Okay. So no one is a god. So everyone does the mistakes. In the interview, they may ask you what are the recent errors you have committed. So missing query opportunity, missing some MCC and CC condition, some DRG changes in the respiratory cases. So if you want to code respiratory cases appropriately, you need to check the clinical indicators appropriately. Missing some bedside procedures like echocardiogram, blood transfusions, vaccination, TPNs, PICC, okay, and feeding tube insertion. Okay. What is term deliver? So delivery is between 37 to 40 weeks. Okay. What is the common delivery duration? Like 37 to 40 weeks. What is pre-term? Pre means before the term. Means less than 37 weeks is called as pre-term. Okay. What is post-term? So delivery between 40 weeks to 42 weeks is called as post-term. Okay. What is postpartum? Delivery after 6 weeks is called as postpartum. Okay. So what is the difference between placental abruption and placenta previa? So separation of placenta from the walls of the uterus during pregnancy, specifically when it occurs prematurely, is called placental obstruction or abruption. So what is placenta previa? So placenta previa is a condition in which placenta partially wholly blocks the neck of the uterus, thus interfering with normal delivery of baby is called placenta previa. Okay. So what is neonate or newborn age period? So neonate or newborn both are same. So age period is 0 to 28 days. Okay. So next, what is AICD firing? So AICD means automated implantable cardiovascular defibrillator. Okay, is a small electronic device that is implanted into your chest to monitor and correct an abnormal heart rhythm or arrhythmia. So that is the purpose of AICD. Okay, what is acute blood loss anemia? Okay, so acute blood loss create anemia due to the loss of red blood cells and depletion of iron. This type of anemia also referred to as post hemorrhagic anemia. Okay, in the documentation, if you see post hemorrhagic anemia, you can code acute blood loss anemia. Okay, what is post COVID? So post means basically before after the COVID, also called as late effect of COVID. Okay, sequel of COVID-19 are associated symptoms that develops following a previous COVID. So for late effect of COVID, you need to use EU09.9. Okay. So what is the difference between poisoning and adverse effect? So classification of a condition caused by a drug or another substance when used incorrectly, like overdose, okay, wrong doses, non-prescribed drug, and given mistaken in physician office, any drug along with alcohol and illegal drug use like cocaine, heroin, marijuana, or opiates. These are the examples for poisoning. Okay. So adverse effect classification of condition caused by drug or another substance when used correctly. So when used incorrectly, poisoning. When used correctly, adverse effect. What is underdoses? Reduced dose medications. Okay. Reduced dosage of medication. For example, patient is having hypertension. Patient will tell to use losartan 25 grams. But if the patient uses only 10 grams losartan, that is the underdosing. So taking lesser doses where patient describes 25 grams. Okay. What is sequela? So any condition developed after acute phase of illness or injury is called as sequela. Okay. So okay team. So in this session we have discussed total 25 Q&A. If you have any doubt in inpatient coding interviews, please mention the comment section of video. And if anyone looking for jobs in UAE, USA and India, please join in our WhatsApp group. Group link is in the description of this video. And also if anyone looking for same day surgery coding training, IPDRG training, SCC coding training, CCS certification, you can contact 707-526-3939. So if you like this session, please click on like button and also encourage your friends to watch this video in order to successful in inpatient coding.